Yeah, in the morning we finished with 46, but I was thinking about something else. Okay, with groups 1, 2, and 13, we'll continue on Wednesday at 1:30. And then you remind me which slides we should start from. Now, the last slide we discussed in the morning was 46, so now we should go back to slide number 35. But before we discuss 35, we'll start with 39, colorectal adenocarcinoma, because 35 is metastasis in a lymph node by an adenocarcinoma, and I would like to make a link between these two slides. So now I'm sharing with you slide number 39, colorectal adenocarcinoma. The tumor is on the left side of the slide, and the right side will help us recognize the organ. Just a second, I'm sorry. I'm back. Sorry. So the right side of the slide helps us recognize the organ, where we can find all of the normal layers of the colon, starting with the mucosal layer, which is composed of crypts. These crypts are lined by goblet cells, which contain large mucin vacuoles. Directly under the mucosal layer, there is a thin layer of smooth muscle tissue, which is lamina muscularis mucosae. After it is the submucosal layer, which is composed of connective tissue and blood vessels. Then there is a thick layer of smooth muscle tissue, which is lamina muscularis propria. Subserosal layer follows, and finally is the serosa. The serosa is the outermost layer, which is lined by mesothelial cells. Yes, mucosal layer, lamina muscularis mucosae, submucosal layer, lamina muscularis propria, subserosa, and serosa. And then we move to the left side of the slide, where we can see the tumor composed of glands. These glands have lumina lined by tumor cells. These cells show features of cellular atypia with increased nucleus to cytoplasmic ratio, presence of prominent nucleoli, hyperchromatic nuclei, the nuclei are darker than normal, pleomorphism, so the cells are with different shape and size, and at many areas, these glands are fused together. The fusion of the glands is visible at areas when there are adjacent lumina, but these lumina are separated only by tumor cells. There is no stroma between them. So the absent stroma means that there is fusion of the tumor glands. Actually, fusion is possible only for tumor glands because they do not have basement membrane surrounding them. Otherwise, the benign glands are surrounded by basement membrane, which prevents the fusion. Malignant tumors have no basement membrane, so the glands may fuse together. And when such fusion of glands is seen as one structure with smooth circumference with the stroma, this is what we call a cribriform structure. Cribriform structure. Also, within the stroma, there is infiltration by lymphocytes and plasma cells. You know that this is the stromal reaction. We discussed it in the morning. The stromal reaction of the malignant tumors. To repeat about the cribriform structures, a cribriform structure is a zone where we have fused glands with secondary lumina inside. These are secondary lumina within one whole structure with smooth circumference with the stroma. This is a cribriform structure. It looks like a Swiss cheese. So finally, based on this description, when the tumor forms tumor glands, then our diagnosis must be adenocarcinoma. And you know that after description of the tumor, you'll be asked about grading and staging. About grading, this is level of differentiation. For adenocarcinoma of the colon, it could be well, moderately, or poorly differentiated. Here in this case, we'll choose the moderately differentiated tumor, or G2, because of the fact that most of these tumor glands are already fused together. Usually in G1 or well differentiated tumors, the tumor glands are predominantly separated by stroma and they infiltrate as single glands. But here, these diffuse areas of fusion with formation of cribriform structures is characteristic for G2 or moderately differentiated tumors. About staging, I will repeat again that for staging, the TNM system is used, and just a second. So the TNM system is used for staging, and for whole organs, the T stage is defined based on the depth of infiltration into the wall, or this is the endophytic growth of the tumor. So here we should evaluate to which layer of the wall the tumor glands already infiltrate. That's why we should follow the normal layers that we saw from the very beginning. And here we see that the tumor glands already infiltrate the submucosal layer. And even the superficial portion of the lamina muscularis propria is also invaded. So here we have bundles of smooth muscle cells, which are already infiltrated by the tumor glands. So in a case like ours, when the tumor glands infiltrate the lamina muscularis propria, yeah, that's right. It means that the tumor is T2. It would be T1 if the tumor glands were only in the submucosal layer. T3 is when the tumor glands infiltrate through the full thickness of lamina muscularis propria and already invade the subserosa. This is T3. And T4 is if the entire wall is completely infiltrated by the tumor, and then the tumor continues infiltrating the serosa and surrounding structures. Then it's T4. In our case, it's T2. During my classes, I mentioned that the epithelial tumors, such as the adenocarcinoma, usually prefer the lymphatic way of spread. So the first metastases from such a cancer most commonly are found in the regional lymph nodes. Of course, then with the progression of the disease, distant metastases are possible as well. Distant metastases usually happen through the hematogenous way of spread. And the most common distant metastases from adenocarcinoma of the colon are found in the liver. Because when we follow the venous outflow from the colon, you know that the blood goes into the portal vein and then into the liver. That's why here is the place where we find the most common distant metastasis. And now we continue with slide number 35, adenocarcinoma metastasis in a lymph node. I wanted to discuss it directly after the primary tumor of the colon to show you how the tumor may occur after spreading through the lymphatic system, of course. The tumor glands are found in these more loose areas. Actually, here on the slide, we have 3 separate lymph nodes. And in only 2 of them, there is metastasis. Here, the loose areas, and this upper side of the middle lymph node, again, there is metastasis. The left one is quite normal. It is composed only of lymphatic tissue. The lymph node could be recognized based on the lymph follicles with germinal centers. Note that there are no centrally placed arterioles here, as it is in the spleen. Also, there are no trabecular structures, as we saw in the spleen. So here, we have only lymph follicles with germinal centers. Some sinusoids as well. And this is a lymph node. Also, the lymph nodes are encapsulated lesions. There is a capsule separating the lymphatic tissue from the surrounding fat tissue. And then we see that there are some loose areas, as I mentioned. And when we zoom in at these zones, we can find again tumor glands. Why we know that they are tumor glands? Because they are lined by cells showing features of cellular atypia. I won't repeat these features again. You can use this information for any malignant tumor that you have. I mean, you can use the information about features of cellular atypia. They are different. Um, Also, in the lumina of these tumor glands, we can find mucin production. This bluish thing is mucin. Again, some of the glands are fused together. And here, obviously, it comes to the diagnosis. I would say that it's more bluish. It's not that whitish, but bluish substance in the lumen of the glands. Yes, is mucin or mucus. So here we come to the diagnosis adenocarcinoma metastasis in a lymph node. The slide is number 35. And we know that this is a metastasis because of the fact that normally there is no epithelial tissue in a lymph node. So it means that this can't be a primary tumor in a lymph node. The primary tumors derived from lymph nodes are known as metastasis, are known as lymphomas. I'm sorry. So here, when we have adenocarcinoma in a lymph node, it means that it is a metastasis from another primary tumor. Here again, in the right lymph node, there is a zone with formation of tumor glands. And if you are asked from what kind of tumor could it come from, or from which organ, where could be the primary tumor located, then you can answer on the first place adenocarcinoma of the colon, because I hope you can see the resemblance with the tumor that we just saw a few minutes ago. But yeah, it could be from an adenocarcinoma from any other site, from the stomach, for example, as well, pancreas too. Yeah, the fused glands here are visible when we have adjacent lumina separated only by tumor cells. When there is nothing else than tumor cells between two lumina, means that they are fused together. Otherwise, there should be the lymphoid tissue from the lymph node between the glands if they are not fused. So the fused glands are elsewhere. Here again, these are, okay, here is better visible. This is one lumen, another one, a third lumen, and in between them, there are only tumor cells, which means that these glands are fused. There is nothing else to separate them. Any other questions? The next slide is number 36. Squamous cell carcinoma, keratinizing squamous cell carcinoma. The tumor is on the left side of the slide. And then the right side, we can find some normal tissue. When we zoom in, we can see that these are bundles of smooth muscle cells. So now we are searching for an organ which has quite thick layer of smooth muscle tissue. All of this layer is smooth muscle tissue. And this organ should have squamous epithelial lining as well, because when we have squamous cell carcinoma in an organ, it means that there is squamous epithelium in this organ. And such an organ is the cervix. The cervix, the exocervix that protrudes into the vagina, is lined by squamous, non-keratinizing stratified squamous epithelium. And you know that there is a thick, smooth muscle layer in the cervix as well. So here we can say that the specimen is from the cervix. The esophagus is the other organ that is lined by non-keratinizing stratified squamous epithelium, but it doesn't have that um, thick layer of smooth muscle tissue. Its smooth muscle layer is much thinner. And then we concentrate on the appearance of the tumor. And we can find that there are nests of tumor cells. These nests of tumor cells are the parenchyma of the tumor, and the stroma is the paler thing separating the nests. And here in most of the nests of the tumor cells, we can find keratin pearls. So this is keratinization. Here as well. When the keratinization in the center of the tumor nests acquire this laminated onion skin appearance, this is known as keratin pearl. Also, there is a quite well visible resemblance of the tumor nests with the squamous epithelium. So here I would say that we can't be confused with any other histological variant of a tumor because of the formation of nests of cells. These nests of cells peripherally have darker layer, so somehow it resembles the basal layer of the squamous epithelium. And then there is some maturation and differentiation finally of, with formation of a keratin pearl. At low magnification, I think that the nests are darker and the stroma is the thing that I think you mix up the terms. The nests themselves are the parenchyma of the tumor. So here, this is one nest. The darker peripheral thing, together with the paler central thing, this whole structure is one nest. And the stroma is the thing that separates the adjacent nests. Within the stroma, there are lymphocytes. This is the stromal reaction of the tumor. And the nest has has darker peripheral structure, peripheral zone actually, and paler center because of the still presence of some differentiation and maturation of the cells. So these features are used for grading of the tumor. When we have some differentiation and maturation of the cells, although they are tumor cells, and even in the center there is keratinization with formation of keratin pearls, it means that this is one well differentiated tumor or G1. Here there is another nest. This whole thing is a nest of cells. And then the stroma is pinkish, more pinkish, I would say. And it contains lymphocytes, these dots. Did you get it this time? Okay. And so I already discussed the grading, which is exactly based on the similarities of the tumor with the normal tissue from which it arises. About staging, here we can't exactly say what's the stage because for the cervix, we need to measure exactly the depth of infiltration, how many millimeters it is. So now it's not possible. We do not have a scale here. When we evaluated the specimen under a microscope, there are some scales that we use and we measure exactly what is the depth of infiltration. Here it's not possible. Also, it's important if the tumor infiltrates adjacent structures like the vagina, for example. So yeah, here we can't say exactly what's the stage. Okay, so finally we make the diagnosis keratinizing stratified squamous, not stratified, sorry, yeah, keratinizing squamous cell carcinoma. Questions? Slide number 38 is the next one, basal cell carcinoma. Again, I think it's quite obvious where the tumor is. It's the darker area of the slide because of the hyperchromasia of the cells, of the tumor cells. So initially we'll zoom in on the left side where we can find the normal tissue, which is the skin again, because we see the keratinizing stratified squamous epithelium together with skin appendages. These are hair follicles. The hair inside is visible. There are some sweat glands as well, like these ones. So with these characteristic epithelial lining and skin appendages, we can say that the specimen is from the skin. And then we concentrate on the tumor mass, which obviously has a connection to the overlying epithelium. We can see that some of the tumor nests are connected to the overlying epithelium, and they start from the basal layer. And also the tumor cells resemble the basal cells from the stratified squamous epithelium. But of course, the tumor cells show features of cellular atypia. The increased nucleus to cytoplasmic ratio, even nucleoli are seen in some of them, hyperchromasia. But at the same time, the cells are monomorphic, so they look like each other. A quite characteristic finding is the presence of palisading nuclei at the peripheral area of the nests. Palisading means that here the nuclei are parallel to each other and perpendicular to the surrounding stroma, which means that so here these nuclei look like a fence. This is palisading. At medium magnification, it's even better seen, I would say. Here too. When we zoom in, these parallel nuclei are really quite well visible. Again, there is stromal reaction in the stroma that separates the tumor nests. Here there are many lymphocytes. This is one plasma cell with a Russell body. Just to remind you that Russell bodies are protein accumulations within the plasma cells. These are immunoglobulins that accumulate in the cytoplasm of plasma cells. There is another one here. Yes, the palisading nuclei peripherally in the nests are quite characteristic feature of basal cell carcinoma. This thing in the center, this is some degenerative changes, cystic changes are visible here and there. Another characteristic feature is the more myxoid appearance of the stroma surrounding the nests. So here you can see the stroma pillar, the stroma that is directly surrounding the nests. This is the myxoid appearance of the stroma. Sometimes during the exam you're asked about the gross appearance of this type of tumor. It is known as ulcus rodens. Because it occurs as a reddish papule at the beginning, which soon after that undergoes necrosis in the center. So finally it looks like an ulcer. Usually affects the skin of the face. And actually this is a tumor found only on the skin. There is no other organ with basal cell carcinoma. So this is a tumor characteristic only for the skin, the most common one. Another characteristic feature is that it never gives metastasis. It's locally highly invasive, but doesn't give metastasis. Yes, the ulcus rodens is because of the gross description of the tumor, because it occurs as an ulcer. At the beginning, it occurs as a red papule. Yes, it is. But soon after that, this papule undergoes necrosis in the center or ulceration. So finally, it looks like an ulcer. So ulcerated lesion on the face is highly suspicious for basal cell carcinoma. Slide number 14 is the next one.
I'm sorry, could you show the Russell's bodies? I didn't see them.
Yeah, sure. Just to share the slide again.
Thank you.
I found some here in this area. Here it is, the pinkish globule within the cytoplasm of a plasma cell. This is a Russell body. Here there are some as well. Okay, now I'm sharing slide number 40, papilloma of the skin. The papilloma is the elevated lesion over the skin. So initially we'll zoom in at the peripheral areas. To recognize the skin, you already know the characteristic morphology with keratinizing stratified squamous epithelium, hair follicles, sebaceous glands, sweat glands. So this is the skin. There is some skeletal muscle as well here. These pinkish cells with peripherally located nuclei. These are nuclei of the skeletal muscle cells. And then we concentrate on the appearance of the tumor, which is seen as tree-like projections. These are the papillary projections with fibrovascular cores lined by epithelial cells. Note that here the cells show no features of cellular atypia. To remind you that benign tumors such as papilloma show only tissue atypia but not cellular atypia. So here the tissue atypia is visible based on the fact that the cells are the same like the peripheral ones, but they form papillary projections. These papillary projections are abnormal for the skin. That's why this is the tissue atypia. Formation of abnormal structures by the typical cells for the tissue. So we have the same squamous epithelium, but it forms papillary projections. Again, I repeat, there are no features of cellular atypia. And also there is hyperkeratinization. So the keratin formation in this area is increased compared to the peripheral areas. I already mentioned that this is a benign tumor derived from squamous epithelium. Papilloma could also arise in a urinary bladder or other structures that are lined by transitional cell epithelium, but then it's called transitional cell papilloma. Here, this is squamous cell papilloma. Could be formed not only on the skin, but also on other parts lined by squamous epithelium, like the oral cavity, the true vocal cords as well. Questions? And yeah, very commonly these lesions are associated with human papilloma virus, but low-grade variants like type 6 and type 11, they may lead to formation of a papilloma. And I forgot to mention about the squamous cell carcinoma of the cervix that is associated with high-risk types of human papilloma virus like type 16 and 18. Slide number 41 follows. This is leiomyoma. The tumor involves the left side of the slide, and based on the right side, we can see the normal tissue which give rise to this tumor. And when we zoom in here, we can see the bundles of smooth muscle cells. But note that here in the normal tissue, the bundles of smooth muscle cells are parallel to each other. While in the tumor, we can see almost the same type of bundles of smooth muscle cells. So the cells again show no features of cellular atypia, but here the bundles of smooth muscle cells are interlacing. So they are not always parallel to each other. For example, here you can see some bundles that are cut longitudinally. The cells have elongated nuclei and they are spindle shaped. But next to it, there is another bundle like this one, which looks different because of the fact that it is cut transversely. If you imagine that this bundle could be cut this way, then the cell will get a round shape with round nucleus. This is because of the cutting section. And some other bundles are cut in an oblique pattern. So they acquire a medium shape between the spindle-shaped cells with elongated nuclei and the transversal ones. So this different type of cutting of the bundles of smooth muscle cells shows that these bundles of smooth muscle cells are interlacing. They are not only in one dimension. So exactly here, this is the tissue atypia of the tumor. The interlacing bundles of smooth muscle cells, because normally they are parallel to each other. And again, no features of cellular atypia, because leiomyoma is a benign tumor. Such a thick layer of smooth muscle tissue is characteristic for the uterus, and actually this is the most common place for leiomyoma. Although leiomyomas could be formed elsewhere in the human body where there is normally smooth muscle tissue, like the wall of the intestine, stomach, esophagus, urinary bladder wall as well, but most commonly it's in the uterus. Even at low magnification, it looks well demarcated, as it's quite characteristic for benign tumors. Questions? Yeah, the wall of the intestine, the stomach, urinary bladder wall. The esophagus also contains a layer of smooth muscle tissue. So elsewhere in the human body where there is normal smooth muscle tissue, it may give rise to a leiomyoma. And leiomyosarcoma as well. You can be asked about the malignant counterpart. Then you should mention leiomyosarcoma. Questions? Slide number 42, lipoma. Here again, because of the fact that this is a benign tumor derived from fat tissue, there are no features of cellular atypia, which means that the tumor is composed entirely of mature adipocytes. But these mature adipocytes are within a capsule. So they form a tumor mass that is encapsulated. Peripherally, we can find the capsule of the tumor. When we zoom in, you can see the smooth, the capsule that is composed of connective tissue or fibrous tissue. And as I mentioned, the tumor itself is composed of mature adipocytes with different size. In some of the textbooks, you see that just usually in lipomas, the cells differ more widely in their size. So, for example, there could be more than 10 times difference in the size of two adjacent cells, like this one and this one, for example, which is not that characteristic for the completely normal fat tissue, but still this is not a feature of cellular atypia. All of these are mature adipocytes. And within the tumor, there is lobular architecture. So there are lobules that are separated by fibrovascular stroma. These lines are the fibrovascular stroma. Here again. And here too. Lipomas usually are located in the subcutaneous tissue, most commonly of the head and back, but of course they could be seen also in the other areas with fat tissue like the abdominal cavity, again in the wall of the internal organs, the intestines, the wall of the stomach, retroperitoneum. The next slide I would like to show is number 45, liposarcoma, which is the malignant counterpart of the previous tumor that we discussed, to show you the differences. Here you can see that the tumor is definitely not encapsulated. There is no fibrous capsule. The entire slide is composed only of a tumor. There is no normal tissue. And also we can find areas with mature adipocytes. But the other difference, along with the fact that there is no capsule here, the other difference from the lipoma is the fact that in this tumor, along with the mature adipocytes, we can find also many cells showing features of cellular atypia. At medium magnification, the darker areas that are visible are exactly due to features of cellular atypia. Here you can find cells with really enlarged cells, enlarged nuclei, which are hyperchromatic. There are multiple nuclei in some of the cells, so some of the tumor cells are multinucleated. Here again. And something that is really important to make the diagnosis liposarcoma is the presence of lipoblasts. Lipoblasts are cells which contain several lipid vacuoles, smaller lipid vacuoles in the cytoplasm, compared to the mature adipocytes, which contains only one large lipid vacuole. The lipoblasts contain several smaller lipid vacuoles. For example, here in this cell, there are 3 lipid vacuoles. And again, the nucleus, actually here there are several nuclei of the tumor cell. They are centrally located, but not peripherally compressed, like in the mature adipocyte. These are tumor cells again. but only the ones which contain lipid vacuoles, like this one as well, are called lipoblasts. The, other, the others are just immature atypical mesenchymal cells. So in one liposarcoma, there could be both variants of cells, immature atypical mesenchymal cells together with lipoblasts. All of these are tumor cells containing one or more nucleus. This is a lipoblast as well. There are several smaller lipid vacuoles in the cytoplasm. And just to show you another finding that you shouldn't discuss from the very beginning, because this is an additional finding on the slide. It is the fibrinoid necrosis in the wall of some of the vessels, blood vessels. These are blood vessels with eosinophilic homogeneous material in the wall, which is fibrinoid necrosis. Here again. So wait for a question about the fibrinoid necrosis. If you are not asked what is this, don't mention it. At the beginning, you should focus on the morphological features helping you to make the diagnosis liposarcoma. Really doesn't matter where you zoom in, all these dark spots here and there are immature malignant cells. Here as well. Note the lipid vacuoles in some of them. This is a lipoblast. These are tumor cells too. This is a lipoblast as well. So here the diagnosis definitely must be liposarcoma. The absent capsule and the presence of atypical cells, some of which are lipoblasts, are enough to make the diagnosis liposarcoma. In contrast to the lipoma, the malignant variant is found in the deeper areas. So the retroperitoneum, the deep soft tissues of the thighs, but not superficially located as it's characteristic for lipoma. Questions? Slide number 43 is next, hemangioma. Lipoma was number 42, and we just discussed slide number 45, which was liposarcoma. Just a second. I can't get the question. You want me to discuss again slide number 42? Or what's the... Okay, but it will be really briefly because I do not have time. This is the slide for lipoma. There is a capsule that is peripherally located. It is composed of connective or fibrous tissue. And the tumor itself is composed of lobules of completely mature adipocytes, which show no features of cellular atypia. All of these are mature adipocytes. Just perhaps there is a wider range in the size of the adipocytes. Some of the adipocytes are around 10 times smaller than others, which is not that typical for the normal fat tissue. But this is not accepted as a feature of cellular atypia, but just as a finding in lipoma. So the tissue atypia here is the thing that makes it a tumor, and the tissue atypia is seen based on the fact that this mature fat tissue is encapsulated. So it forms a tumor mass. Actually, here we do not have the whole tumor mass. Of course, this is only part of it, but imagine it as the whole tumor mass that is encapsulated. Otherwise, the fat tissue, you know that it does not stay as nodular masses, but it's more diffuse. Slide number 43 is the next one. No problem. Here again, we have something that helps recognize the organ, and it is an epithelial lining. Peripherally, when we zoom in, we can see keratinizing stratified squamous epithelium. Actually, it doesn't matter where you zoom in. Here, it's just a little bit thinner, but still keratinizing stratified squamous epithelium. There are no skin appendages, but yeah, the stratified squamous epithelium could be seen only covering the skin. All of the other parts in the human body where we can find squamous epithelium, it is non-keratinizing. And then in the subepithelial tissue in the derma, we can see proliferation of endothelial cells. And these endothelial cells form small blood vessels, capillaries, which are filled with erythrocytes. Here again, doesn't matter where you zoom in, we have proliferation of endothelial cells forming capillaries. And it's really important that the endothelial cells show no features of cellular atypia again, because otherwise, during the exam, the examiner can try to make you more confused when you make the diagnosis hemangioma, when saying that, but this tumor has somehow large size, somehow it resembles infiltrative growth or something. How are you sure that this is hemangioma but not angiosarcoma? So the main thing that you should use is the absent features of cellular atypia. And yes, sometimes the hemangiomas, although they are benign, they are large tumors with irregular borders. So This is a characteristic finding for some of the hemangiomas. Here, the fact that the tumor is composed of capillaries makes it capillary hemangioma, because there is another variant that is cavernous hemangioma. Cavernous, because the endothelial cells form cavernae, which are larger blood vessels. So finally, here for this slide, you make the diagnosis hemangioma of the skin. Of course, the tumor could be formed in any other organ. From the internal organs, perhaps the most common one is the liver. Where we can find hemangioma. Questions? Slide number 44 is the next one. Again, the entire slide is composed of a tumor. There is nothing normal. I mean, there is no normal tissue here. But the tumor has really characteristic morphology. So again, it's quite enough to make the diagnosis fibrosarcoma. First of all, the tumor has fascicular growth pattern. So it forms fascicles. The cells are spindle-shaped with elongated nuclei. But at the same time, the nuclei or the cells are monomorphic. They look like each other. They are hyperchromatic. The nuclei are hyperchromatic, I mean. And we can find many mitotic figures, like this one. This dark spot with uneven margins, this is a mitotic figure. There is another one here. Another mitotic figure. Another one. Actually, here the cells are almost separated. Another mitotic figure. So there are many mitotic figures dispersed throughout the slide. You know that the mitotic figures are characteristic for malignant tumors, or at least many of them. This is another mitotic figure. And the other really characteristic feature is the fishbone or herringbone pattern of growth. This fishbone pattern of growth, imagine the fishbone, and here it is visible again with fascicles which are somehow interlacing, because here we have one longitudinal section through a fascicle and another one that is cut in more oblique pattern, and this gives the appearance of a fishbone. The angle that is formed between the adjacent fascicles. Here it's seen again this way, and the other fascicle is cut in a different way. Here too. once again. There are some areas with hemorrhages, but again, you know that the hemorrhages are characteristic for malignant tumors. So finally, based on the description of the tumor with fascicular pattern of growth, also forming this fishbone or herringbone appearance, these monomorphic elongated cells, spindle-shaped cells with elongated nuclei, which are hyperchromatic and enlarged. Also, the presence of many mitotic figures. All of these features are showing that the tumor is fibrosarcoma. Again, the tumor grows in the deep soft tissues, in the deep soft tissues of the thigh, also the retroperitoneum. And don't forget that the malignant mesenchymal tissues or sarcomas are are more associated with the blood-borne metastasis. That's why usually the metastases from sarcomas are found in the lungs. The lymphatic pattern of spread is really uncommon for the mesenchymal malignant tumors. Okay, these were all of the slides from tumors, but now I remember that with group 9, I think, I haven't discussed slide number 1, 2, and 12, right?
Yes.
I can't get exactly the question for fibrosarcoma. Exactly because it's malignant, it's fibrosarcoma. We use the, yes, sarcoma means malignant tumor. The benign tumor would be called fibroma. So exactly the word sarcoma shows that the tumor is malignant. And the features we saw were characteristic for the malignant variant. Carcinoma is, yeah, you're partly right, but carcinoma is again a malignant tumor, but with epithelial origin. Sarcoma is from mesenchymal origin. Please learn the names of the tumors. Slide number 1 is the next one. No problem. Hope you won't be confused during the exam. Slide number 1. The slide is with the name nutmeg liver. You know that the liver initially is discussed, it initially is recognized based on the Porter triads mainly. So at medium magnification, when we find some round to oval structures, which contain several lumina, and when we zoom in at these structures, we can see a bile duct, which is lined by cuboidal cells with round nuclei. Then there are also blood vessels, which are lined by endothelial cells. The arteriole is the smaller one with thicker wall, and the other one is the venule with thin wall. And another example here, for example, this is the bile duct lined by cuboidal cells with round nuclei and blood vessels. The central veins are also quite well visible because they are dilated. The sinusoids are dilated as well and filled with erythrocytes. This is due to the congestion. You know that the nutmeg liver is due to chronic right-sided heart failure. And because of the direction of the blood flow from the portal triage to the central veins, then after fusion of central veins, veni hepatica are formed, which go into the vena cava inferior and then into the right side of the heart. That's why the central veins are closer to the heart. So when there is chronic right-sided heart failure, the congestion starts from the central veins. There are different stages of nutmeg liver. The first stage is congestion. The second is the straight type of nutmeg liver. The third stage is reverse type of nutmeg liver. And the fourth stage is cardiac cirrhosis. We call it cardiac cirrhosis because the cause is in the heart, a problem in the heart with the right-sided heart failure. Here, because of the fact that there is already fusion between adjacent centrilobular areas, this is the third stage, reverse type of nutmeg liver. Because in congestion, only the central veins are dilated and they are filled with erythrocytes. But during the second and third stage, the sinusoids are highly dilated as well. There is necrosis and atrophy of the hepatocytes in the centrilobular areas. So here the centrilobular zones, or the hepatic trabeculae in the centrilobular zones are thinner exactly because of necrosis and atrophy of some of the hepatocytes compared to the periportal areas. Look at the thickness of the hepatic trabeculae here and of these ones. So here, this is the reverse type of nutmeg liver because the adjacent centrilobular areas are already fused together. If this was the straight up type of nutmeg liver, then the pathologic changes are only in the centrilobular areas without fusion. Questions? Slide number 2 is pulmonary edema. Do you want to ask something? Maybe it was just a mistake. Okay, slide number 2 is the next one. Pulmonary edema. The lung parenchyma could be recognized based on the alveolar spaces. This is the parenchyma of the lung. Some of them are empty, but some others, actually most of them, are filled with homogeneous pinkish fluid. Exactly, this is the edema. Also here, there is one lumen that is lined by pseudostratified columnar ciliated epithelium. There is no cartilage and glands in the wall, which means that this is a bronchiole. In the interstitium, there is black pigment. This is the anthracotic pigment. Macrophages filled with coal dust. The coal dust comes with the air. Everybody who breathes also coal dust from the air. This coal dust then is phagocytosed by the alveolar macrophages, which then move to the interstitium. And this is where we can find the coniophages. This is how we call these pigmented cells. The homogeneous pinkish fluid is the morphological appearance of lung edema, which is due to acute left-sided heart failure. The most common cause for acute left-sided heart failure is myocardial infarction. It leads to abrupt increase in the hydrostatic pressure in the lungs so that the plasma leaves the blood vessels into the alveolar spaces. The coal dust, yes. Initially, the coal dust is phagocytosed by the alveolar macrophages, but then the coniophages move to the interstitium where they deposit. The coniophages never stay in the alveoli. So yeah, here you can compare the plasma from the blood vessels with the plasma in the alveoli. Of course, the plasma does not leave these large blood vessels, but the capillaries that are in the alveolar septa. To be possible for the blood cells and plasma to leave the blood vessels, a thin wall is needed, which is possible only in microcirculation. Now I want to show you slide number 12 because it looks almost the same way, although its name is anthracosis in the list of specimens. But you see that again, we have a specimen from the lung parenchyma with empty alveolar spaces and others which are filled with homogeneous pinkish fluid. So it means that again, there is some evidence for lung edema. There are some black areas which are the anthracotic pigment. Here they are. Macrophages with anthracotic pigment. So yeah, for these two slides here in the center, there is one lumen that is lined by pseudostratified columnar-ciliated epithelium. It is a bronchiole again because there is no cartilage and glands in the wall. So yeah, it doesn't matter which one of these two slides you get during the exam. Please discuss both processes, the anthracosis and lung edema, because both of them are present. And I think that slide number 3 was discussed together with the other group. I started from slide number 3 when you were both groups together. Okay. So now we can finish the class. Just to remind groups 1, 2, and 13 to join the class on Wednesday at 1:30 to discuss the other slides which we haven't discussed with you. And yeah, for the others, I wish you Merry Christmas, good luck for the session, and study harder, please, because this is not a joke exam. Many of you will fail, I'm sure. Yes, the practical part of the exam consists of 2 microscopic slides only. The head of the department decided not to give you a jar with gross specimen. So initially, if you pass the MCQ, then you continue with 2 microscopic slides. If you pass this part as well, you have the theoretical exam. Only the MCQ is saved. What happens if you fail the retake? If you fail the regular exam and then the retake, right? There is another session in September. If you fail in September, then you start to pay for any other try to pass the exam. These are free. Actually, they are not free, but they are included in your regular tax for the semester. Yes, that's no macroscopic exam. Yes, there is no jar with gross specimen. Only 2 microscopic slides. Okay, you're welcome. Yeah, I hope so. Yes, you can join the class on Wednesday if you want to, it's not a problem. But we will discuss slides which were discussed with your groups. If you want to hear them again, it's fine. I think from number 14 to 26. You're welcome. Have a nice day. Bye.